Good morning, friends. A warm welcome to our distinguished faculty, guests, and students. In 2024, 589 millions of adults live with the diabetes worldwide, the number rising 853 millions by 2050. Diabetes led to death 3.4 million death globally in 2024. We are honored to have with us Dr. Bansi Sabu, whose leadership adds so much to this event. So for the next session, I would like to invite chairperson on stage, Dr. Bhupendra Shah sir from Himmatnagar, Dr. Sudhanshu Patel sir from Ahmedabad, and Dr. Bhumi Dave madam from Rajkot.
Good morning, everyone. We would like to welcome everybody. We are commencing our second day talk with Start AM trial with Dr. Bansi Sabu. He doesn't need any introduction. He is a chief organizer and chief diabetologist of the DiaCare clinic in Ahmedabad. Over to Bansi.
Thank you. So, Bhupendra Bhai, he is a man of IMA, he is a man of Association Physician of Gujarat and very close friend. So, along with Sudhendu Bhai and Bhupendra Bhai, thank you for kind words. What I am going to talk in next 20 minutes, it's a talking of a new trial which we have done with acarbose and metformin. Can we think of starting it with a newly detected diabetic patients? And this is what I'm going to talk. It's an Indian diabetic patients are the difference. What alpha glucosidase inhibitor they do and what's the need of combination in newly diagnosed patients. We will have some real world evidence which is acarbose and metformin, a fixed dose combination in a newly diagnosed type 2 diabetic patients. Now to start with, starch study. I'm sure all those who are practice diabetes, they know about the starch study which is Shashank has done. That this is what the carbohydrate constitutes around 65%, 64.1% of total energy from diet. And this is true in our clinical practice. When you talk to your patient, you will find that what they are eating is only carbohydrate most of the time. And if you just try to find it out in some of the patients, I have seen it's almost 75%, 80%. Even when I try to calculate my own carb intake in full day, I found it's almost 70%. And the post-meal glucose in 62.5% diabetic population were above the target of 180. So it is your PPG which is contributing an important factor for uncontrolled diabetes, even for a newly detected diabetes. If you do your continuous glucose monitoring, even in an IGT patient also, you will find it is the post-meal peak. Your fasting may be even 100. So this you will find also in a continuous glucose monitoring. We know from our pathology day of MBBS that first phase of insulin secretion goes first. That's what the pathophysiological defect in type 2 diabetes. And that's the reason your first phase is gone and whatever the carbs you have taken, it is going to give you the peak. So in the first, you will find the post-meal your glucose is becoming in 1 hour or 90 minutes or in 120 minutes. If you put CGM, you will find different diets will your peak your glucose level at a different times. So this is what you're going to see in your 160, 180, 200, 250. And your most of uncontrolled diabetic patients mean this is your post-meal glucose is responsible for them. And by continuous glucose monitoring, I have also seen that most patients, and that's the reason our uses of alpha glucosidase inhibitor is very high. If you see the ADA ESD guideline, you will not find even alpha glucosidase inhibitor in their management strategy. It is not there, but we use it easy in our country like anything, and the reason is very, very clear. Increasing 2 hour PPG and with increase in carbohydrate consumption, you can see here many of our patients, even they are going up to the milligram of 225, 230. This is why PPG should be addressed for better diabetes management. If you are controlling the sugar, post-meal hyperglycemia, if your patient HbA1c is somewhere around 8 or 8.5, what you have to deal with only PPG. And I always tell, if you find a patient with a HbA1c of 8.4 or 8.5 or 8.2 or 8, what we used to do, because uncontrolled diabetes with a all triple drug combination, the first thing you should add the insulin. But here insulin will not work. If you do the CGM or if you try to do their fasting and post-meal hyperglycemia, you will find that actually they are fasting at control. It is less than 120 or 110. It is the post-meal glucose level which is the contributing factor for their HbA1c uncontrol. And they need a therapy like alpha-glucosidase inhibitor. The early phase insulin secretion deficiency, you can see here they have done one study, Asian versus Caucasian. The Japanese behave like India also. The China population, Japanese, Indian, Malaysian, we have similar type of that early insulinogenic index and insulin secretion defect. The first phase of insulin is gone, and these are the patients who need alpha-glucosidase inhibitor. You will be surprised, in China, the highest selling brand of alpha-glucosidase inhibitor is Glucobe, and that is #1 brand. Even today, with all SGLT2 and DPP4, there are so many brands which are available. I had gone to their Chinese Diabetic Society meeting, and thousands of doctors, and they are the biggest partner for their meeting. While if you go in ESD or you go to ADA, you will not find even the Bayer stall also. So they are not there, and they all are here. So there is a greater contribution of postprandial hyperglycemia in Asian patient. This, I am sure, Montier et al. Slide you all must be remembering from 2003. We all talk that if your patient HbA1c is less than 8.5, it is the postprandial hyperglycemia which is a major contributing factor. If you find your patient HbA1c is more than 9 or 8.5, it is fasting as well as postprandial, both are contributing factor for those patients. This is what in an Asian study they have done. So that's very, very important. You just can't chase only HbA1c, and by targeting HbA1c of less than 7 will not keep you under target, because they may go more in hypoglycemia. So make sure that you do their fasting, post breakfast, post lunch and post dinner. I always ask my patient to do, if they can't do continuous glucose monitoring, please do post breakfast, post lunch and post dinner. All three sugar, maybe once in a week time or once in a 2 week. That is what they have to do. The IDF guideline, this is the International Diabetes Guideline, which we have published in 2011. And why I am showing here, Durvi is right here in front of me. We are again preparing IDF post-meal guideline. So it's the International Diabetic Federation post-meal guideline, which was published in 2011. And the same guideline, we are publishing the targeting fasting and postprandial. It's an important strategy. This is level 1 evidence. The baseline HbA1c start with the initial combination therapy with 7.5 to 9. And the mechanism of action is, it's a complementary action, which one side you are taking care of insulin sensitizer, metformin and other combination of adding acarbose for these patients. And this is what a comprehensive control for fasting, PPG and HbA1c both. Acarbose primarily taking care of PPG level where it originates. It slows down the carbohydrate absorption from small intestine, and this is what happens with acarbose. So acarbose is not for a weight reduction. So there is some confusion. Many doctors also think that actually it is carbohydrate restrictor, but that carbohydrate will get absorbed, but not in next 1.5 hours or 2 hours. It will get absorbed over a period of time, maybe in 4 hours or 6 hours. So this is what the acarbose, it delays intestine carbohydrate absorption, leads to lesser insulin need and protection of beta cell. Carb in lower intestine facilitate GLP-1 release and gut symbiosis. And there it is the reason that it helps in maybe some weight reduction, because it will give you a fullness, a feeling of fullness will be there with the GLP-1. So it lower post-meal hyperglycemia and improves insulin sensitivity. It's a molecule which is absolutely insulin sparing action. So that's again very important. It is not the SGLT2 first came without insulin sparing action. The first molecule which had come without nothing to do with the insulin is your acarbose or your alpha glucosidase inhibitor. These are the molecules which are available. This is 25 years of acarbose. You know, we celebrate all these things. So this is 25 years. Acarbose has been studied continuously since its launch with India. Robust scientific evidence highlighting its relevance, efficacy and safety in Indian population. A unique mode of action resulting in a clinical benefits. This is insulin sparing action, reduction in postprandial hyperglycemia, acarbose, metformin versus we have done with sulfonylurea and metformin in a real world evidence, and a gut symbiosis due to presence of undigested polysaccharides in lower intestine. So this is comparison between a combination of alpha glucosidase inhibitor with metformin compared with sulfonylurea with metformin. Both will able to achieve a tight control in a patient with 8.5 or 8 or 9, but the more risk of hypoglycemia, while here the patient, the risk of hypoglycemia is significantly reduced. So acarbose for all, it is the only molecule which can be given in any age group. Background therapy can be anything, duration and diabetes, type 2 diabetes, completely insulin sparing action. So even after 25 years of diabetes, somebody is on insulin, putting him on basal bolus, still you can add the acarbose. The baseline HbA1c may be 9 because Indian patients even at 9 fasting and post meal both are high. With 8 HbA1c also your post meal hyperglycemia is there. Even the conditions of beta cells and BMI, it is the molecule which can be even in type 1 diabetes also they have is approved as an adjuvant to diet and insulin. This is the molecule also for the elderly population, newly diagnosed person, and even with the people who have impaired glucose tolerance. This molecule is for prevention of diabetes, someone who had developed IGT and to become a full frank diabetes. So it is approved in all these conditions, even in India too. Considering and choosing combination therapy, addressing high PPG, minimizing cardiovascular risk, enhanced insulin sparing and beta cell protection, low risk of hypoglycemia and body weight gain for a better tolerability and safety profile. Acarbose and metformin is going to address all those gaps because acarbose will take care of PPG while metformin for fasting, insulin sparing action almost both, but that's a metformin is insulin sensitizer. There will be incretin effect. Body weight gain will not be there, will be some weight reduction. Risk of hypoglycemia is minimal with both these molecules. CV benefits are there and beneficial effects on lipid profile too. And this is what the trial which we have published at START AM, which is a acarbose with metformin fixed dose combination, a treatment pattern and outcome in newly diagnosed type 2 diabetic patients in India. This fixed dose combination is a prospective open label observational trial. Is the patient profile. You can see 1728 patients were screened. These many patients were enrolled in 56 centers in India. This was baseline. Patients were given either 25 to start with and increased up to 50 milligram along with 500 milligram, and post-treatment follow-up was done for these patients for 1 month. And here you can see the mean HbA1c of these patients was 8.06, and this is 8-week 24 after almost 6 months it is 7.0 with a HbA1c of reduction of 1. So you know most of Western data will show you that alpha glucosidase inhibitor is a very weak anti-diabetic. They had shown most of the time that acarbose or alpha glucosidase inhibitor reduces HbA1c around 0.4 to 0.6 and better DPP4 will reduce almost 0.8 or 0.9 and then GLP and all other things. But this is not true for Indian patient or the Chinese patients or those who are eating a lot of carbohydrate. It had shown HbA1c reduction of almost 1. There is a progressive reduction in HbA1c from baseline at week 6, 12 and at 24. Glycemic control has become more smoother, no hypoglycemia, no requirement of any additional drug. For 89% of your patient, 56% patient achieve targets of less than 7. That is what you want for your patient. So consistent and effective glycemic control with significant A1C reduction with acarbose and metformin in a fixed dose combination. A secondary outcome was postprandial hyperglycemia change from baseline at week again 6, 12 and 424. Significant PPG reduction of 56 milligram and progressive reduction of PPG starting as early as in 6 weeks. So these patients were having around 219 had come down to 180, 172, 170 and 162. So acarbose, metformin for a very effective for PPG control and reducing the risk of complication associated with elevated secondary outcome. It had shown the fasting plasma also reduced. Now, sometimes people may ask that why there is a fasting plasma. Here there was a metformin which was added. That was the reason insulin sensitizer. And if you have a molecule which is consistently you are reducing post-meal hyperglycemia, over a period of time it will going to have some insulin sensitivity effect, and there will be decrease in fasting plasma glucose also. So consistent reduction appear as early as from 6 weeks, and it will continue for 24 weeks, which was almost a 32 milligram fasting plasma glucose was also reduction. And there is a secondary outcome was one that it was reducing some weight also. So 2.2 kg at end of 24 weeks. So Bhumi Ben, we just remembered you, and please come. So this is 2.2 kg weight reduction was there in 24 weeks. So acarbose metformin fixed dose combination had shown reduce the risk of complication associated with higher body weight and improve metabolic outcome. The secondary outcome for lipid profile, you can see significant reduction in LDL, VLDL and total cholesterol. The idea of giving you the lipid profile report that it's a lipid friendly. So I mean your triglyceride, your LDL cholesterol, everything get reduced. These are the patients who are not put on any lipid lowering agent in this particular clinical trial. The prescribed dose was started with 50 milligram, 500 milligram once daily. So this is very important. I normally start with 25 milligram. And I add with the biggest meal of the day, maybe 1, then you can make 2, then you can make 3, then you can make it 50 milligram and 3 times. So because many of your patients may be intolerant with the acarbose, maybe because of their postprandial fullness, they will not able to tolerate. So just don't write acarbose or voglibose just 3 times a day, because they may become intolerant and they may find that you may have a patient with a complaint of postprandial fullness. So increase slowly also. This is what we have done. GI side effects are common. That's what the fullness is there. Only 0.9% patient had drug related treatment emerged as a adverse events, and these patients continued even with the adverse events which they were having. So acarbose, it was well tolerated. 2 hypoglycemic events were there. They were mild, and some of the patients, with the 200 milligrams, suddenly their sugar becomes 100 or 90 and they may complain. So if you do their continuous glucose monitoring, which we should do ideally for these type of patients, because now in future you will find all prospective observational trial will come with a continuous glucose monitoring. You just can't depend on a symptom, because a patient with from 200, even it comes with 100, they may have some hypoglycemic symptom which was there in 2 patients. So minimal risk of hypoglycemia, majority patient recovered well, no fatality, severity and outcome. To summarize, glycemic control was well controlled with A1C of 1% reduction. This is what majority of patients achieved with the 7%. FDC was well enough to achieve significant glycemic control and significant reduction of PPG. These are the benefits beyond glycemic control for lipid friendly and weight reduction, and well tolerated molecule of this fixed dose combination. To conclude this trial, the acarbose and metformin FDC, which is a fixed dose combination, provides very early, consistent, durable glycemic control along with body fat reduction and improvement in lipid profile. Acarbose metformin fixed dose combination is well tolerated in newly diagnosed type 2 diabetic patient. This could be a preferred choice as a first line combination in these patients. With this, I thank. I'll be very happy if we can have some question. And finished, even we started at 9:05 or 9:10. I finished before that. Thank you.